Hi, everyone. I'd like to introduce Dr. Tejas Shah, who will be giving this month's spinal cord injury in service. He'll be talking about different spinal cord injury syndromes. So this is a really important concept, something that we see frequently, but we don't always think about the relevance to patients. We'll go through this, and Dr. Shah will give us all a nice refresher course that will hopefully help us with our clinical care. Thank you, Dr. Shah.
All right. Thank you so much, Dr. Imroff, for the introduction. So as Dr. Imroff was saying, I'll be doing an overview of the incomplete spinal cord syndromes and, of course, looking at not only the major causes of it, but really the management, the evaluation, and, of course, the prognostic factor, something that a lot of patients with spinal cord injury are really most interested in, their ability to walk again, their ability to gain their sensory motor function, etc. I just lost my screen. Sorry. Are you able to see the screen still? Okay. Oh, okay. Let's see what. All right. Let's try this one more time. All right. We can see it now. Okay. All right, so an incomplete spinal cord syndrome just refers to a lesion of an ascending or descending spinal tract, and this can result from trauma, spinal compression, spinal artery occlusion, etc. We're going to go over 4 of the major cord syndromes right now. This is not an exhaustive list, but I felt the most relevant in this category. So we'll go through them one by one and then talk about the differences, the similarities, and sort of how to really work up each of them. Sorry. Okay. So first, we will start with just overlooking the major pathways. We have motor and sensory. Again, this is not an exhaustive list of all the pathways we have. The anterior horns and corticospinal tracts control really the motor system from our neck down to our feet. And this will be more explained in a minute or so in the next slide, but we really want to talk about tracking, how these tracks sort of go through the spinal cord, where they cross over, because depending on the type of spinal cord injury the patient has, in relevance to this category, we'll find out more about their neurological function. The sensory tracts refer to multiple. One is spinothalamic, that mostly relay pain and temperature sensation. That crosses over at the level of the spinal cord. And then the dorsal columns that you can see here in the blue, I don't know if you can see my mouse, they relay deep touch, proprioception, and vibration. Those are the major senses that it sort of conveys, and it crosses in the medial lemniscus pathway. So why don't we take a more visual approach to this and get a better idea of what's going on here. So right here, I just have 3 of the major pathways. Let's first start on the left. As you can see here, we see these first order neurons, and they cross over in the medulla, which is sort of part of the lower brain that we have, and then they sort of go down this corticospinal tract right here. And this is the corticospinal tract. So notice how they cross over at this section right here. On the middle part, we have the the dorsal column tract. And for this, you can see how the tract runs sort of on the dorsal or the posterior part of the spinal cord, and they cross over in the medial lemniscus, which is also part of the medulla oblongata. And then finally, we have the spinothalamic tract. Now, dissimilar to the first 2 tracts, you notice how at the level of the spinal cord is where they sort of decussate or cross over, and then the information is carried over to the brainstem. So both the dorsal and spinothalamic are the ascending tracts we have, and the corticospinal tracts are descending. Okay, and of course, it's not an exhaustive list, but for the purposes of the incomplete spinal cord syndrome, I think it's relevant as we get started here. And I would just advise you that you continue to sort of refer back to these pathways as we kind of go over the different symptoms of each of these syndromes. Anterior cord syndrome is a lesion that affects the anterior 2/3 of the spinal cord. As you can see here, this is outlined with the red, and the posterior part of the spinal cord is preserved. Causes of this are both traumatic and non-traumatic. One thing you'll see here, that's sort of how this tends to be all over for all of our syndromes, right? The traumatic and the non-traumatic causes. In terms of the non-traumatic cause, this is probably the most relevant cord syndrome for that, because the most common reason, almost 95% of the cases, are referred to the occlusion of the anterior spinal artery that runs from the anterior median sulcus of the spinal cord to the conus medullaris. The conus medullaris is sort of the end of the spinal cord before it gives off peripheral nerves on the end, referred to cauda equina. You can also have severe hypotension. That can be from a variety of issues, such as low blood pressure, hemorrhagic shock, etc. You can also have atherothrombotic disease as well as vasculitis. The common theme here is you sort of have less perfusion. And so like spinal cord, like all of our other organs, they do rely on a blood supply. Additionally, you can also have anterior cord syndrome rising from trauma, such as crush injury, burst fracture, gunshot, knife injury. Presentation of this is that patients will present with motor paralysis below the level of the lesion. And I highlighted in red the tract that's really affected here. That's corticospinal. And then you'll have loss of pain and temperature both at the level of the lesion and below as well. And this is the involvement of the spinothalamic tract. Notice that the vibration position sense is preserved here because that's in the posterior column. Now, I also want to point that this is a bilateral involvement. We can see here on the front end, the anterior spinal artery and the different branches it gives off. Notice that it's going to give supply to both parts of the spinal cord. That's why patients won't have a unilateral presentation. Most likely they will have a bilateral presentation. And depending on the level of where the motor paralysis takes place, patient can be either paraplegic and quadriplegic. Remember that the spinal anterior spinal artery runs from cephalic to caudal. So depending on the level of the ischemia, more sort of widespread symptoms can occur the higher up the injury takes place. Now, another thing to note is that the lateral horn part of the spinal cord is what houses the sympathetic neuron cell bodies. And so when that's affected, you can have autonomic symptoms as well, such as neurogenic bowel and bladder, as well as blood pressure control and sexual dysfunction. For an evaluation, you want to go and get an MRI. That's that's a gold standard. You'll see T2 hyperintensities within the region of the anterior horn. This is presented in the sagittal view as pencil-like, and the axial view, which I've presented here for us, sort of owl's eyes. You can see the two bright dots here in animation sort of present on this MRI scan right here. It's sort of the pathognomonic finding of this. Given that a patient will come in with these symptoms, we don't really know the source. So it's very important to always get blood work to look for a possible infection. We're looking for a possible white blood cell count, follow that out with infectious workup, including blood cultures. And then you also want to get an echocardiogram to rule out sources of emboli that possibly can be coming from the heart. LPCSF can be done if we're concerned about meningitis or infection of the central nervous system at any route. And then, of course, given other symptoms that the patient may have, that may direct you to, direct your workup towards a hypercoagulable and look at drug-related etiologies as well. Okay. Management depends on the cause, and that's going to be a very, very similar theme throughout this presentation. Now, this is one of the syndromes where the non-traumatic issues tend to be a little bit more common than the traumatic ones. Very commonly, the anterior spinal artery is ischemic, and that happens a lot during aortic surgery. As you can imagine, where the aorta is clamped, that can lead to ischemia of the anterior spinal artery. One way to sort of manage that is by making sure you're keeping the mean arterial pressure elevated by using fluid boluses to increase intravascular volume, as well as, if needed, vasopressor medications to increase the SVR. Another thing I noticed upon my review is that some surgeons will have an LP drain to remove excess cerebrospinal fluid, and that has to do with sort of maintaining a pressure within the spinal cord. The more cerebrospinal fluid there is, that might sort of lead to less blood flow within the artery itself. If we are concerned about an atherothrombotic etiology, it's important to thrombolize within 4 to 5 hours of symptom onset. And then, of course, you definitely want to treat the underlying cause of the anterior cord spinal syndrome. So if we are dealing with, for example, an aortic dissection, the patient will be need to taken back to the OR for management of that. And less likely, if there's a vasculitis involved, definitely important to make sure we start with immunosuppression for that. Okay, just give me 1 second. I'm going to go ahead and just slide these slides over. All right. Now I want to move on to posterior cord syndrome. This is a very rare syndrome, the rarest of the 4 syndromes I'm talking about. And as you can see, the red marking has sort of shifted posteriorly. Very similarly, you can think about the deficits here sort of being on the opposite end of the anterior cord syndrome. The dorsal columns are damaged here, so we'll have a loss of tactile sensation, proprioception, as well as vibratory sensation. Now, here, the pain, temperature, motor function is preserved. Etiologies for this exist commonly, including vitamin B12 deficiency, MS, syphilis, usually neurosyphilis, also known as tabes dorsalis, and you can, of course, have an external compression from a posterior tumor as well as spine degeneration. Finally, you can have ischemia of the posterior spinal artery. Now, remember to note, it's important to note that in regards to the anterior spinal artery, these symptoms can be unilateral because there are 2 posterior spinal arteries, and so the blood flow could still be preserved to the other side. Presentation of this is patients presenting with sensory ataxia. They have decreased coordination of their voluntary movement due to lack of proprioception. They have decreased balance, poor coordination, as well as unsteady walking. Patients are able to ambulate. However, there are lesions if they become larger in size that can actually involve motor and autonomic control as well. I like to think of this sort of in a way, if you were to imagine being in a dark room, even though you're able to walk, it's hard to kind of, feel where you're at. So you can understand that even though motor function may be intact, not having that feeling of position that can vary from patient to patient can lead to a lot of issues down the line. And so the patients definitely need to, train themselves in order to move forward with it. Evaluation of this is very important to do a physical exam where we assess different types of sensation, look at temperature, pain, vibration, look at tools to assess for vibratory sense, pinprick, as well as tuning fork. The Romborg test, which I've brought up here, is a very commonly used test that demonstrates sensory ataxia. Patients, when their eyes are closed, will sort of wobble, as you see here. You can also look at blood tests where we can assess for possible vitamin deficiency, including B12, and markers of syphilis. And again, the management or the evaluation is going to be guided by how the patients sort of present. Management depends on the etiology. So for B12 deficiency, you want to supplement with B12 supplements. If it's syphilis, you can treat with penicillin. I believe it needs to be IV at this stage. Spinal cord compression will require emergent decompression. And then, of course, rehabilitation to improve balance and voluntary movement. Right here on the sagittal view of the MRI, you can see a hyperintense signal right here. And that sort of delineates the posterior column. You're also, for people that might want to guess what this is, this represents subacute combined degeneration, and that occurs from B12 deficiency. You can actually also see a hyperintense signal along the corticospinal tract as well. However, for this, we only see the hyperintense signal on the posterior cord. Now we're going to move on to the central cord syndrome. So here, a different picture, because I kind of really want to highlight all the different tracks here. The central cord kind of, as you can see, takes place in the middle. This is the most common form of this is incomplete spinal cord injury syndrome. Going for over 9.9% of spinal cord injuries. Causes of this vary from trauma, cervical spondylosis, as well as atlantoaxial instability. Trauma is the most common form. So the mechanism that's sort of rooted out is hyperextension, as you can see right here. Posteriorly, when we hyperextend, pathologically, you can have an inward bulging of the ligamentum flavum. You can also have anterior compression of osteophytes. Older patients that might be suffering from osteoarthritis may have further advancement of their osteophytes, which make compressing the cord much easier. Presentation for this syndrome varies. It does affect population in a bimodal distribution. We have young males on one side versus older males on the other, and males tend to be more inflicted than females. Younger males will tend to present more after a fall, a motor vehicle accident, really a high velocity type, and their injury stems from a secondary to a fracture dislocation or disc herniation. Older males, on the other end, which might be with advanced osteoarthritis, other spinal pathology at play, such as spinal stenosis, which will more likely present after a fall from a standing height or a low-speed motor vehicle accident. And they're also more likely to have the hyperextension injury that's commonly prescribed to this type of syndrome. Upper extremities are affected more than lower extremities here in regards to motor function. And there's varying levels of sensation, both in light touch and position sense. This right here represents sort of the sensory distribution that you can see with central cord. Notice how these levels are affected here, however, not below. Now, one might ask, why are arms more affected than the lower limbs? One of the theories that people attribute this to is from the somatotropic organization of the lateral corticospinal tract. Something that we don't see is that this is very mechanical in a sense. This circle right here, representing sort of a theoretical central cord syndrome, can vary in its size. So the smaller it is, the less tracts are involved, the sort of greater area it covers, more tracts can be involved. So if it sort of starts small and grows sort of in size, you can imagine that if the tracts involving upper extremity motor function are impacted, that would be much more likely to be impacted in the lower extremities. Bladder dysfunction is very common, and patients will tend to have urinary retention. However, sacral sensation tends to be preserved for these patients. Whenever these patients present, first line is, of course, get an X-ray or CT to assess for any fractures or dislocation. The MRI is the gold standard to evaluate for any injuries to the spinal cord or soft tissue. It's the most consistent imaging finding, where you'll probably see a hyperintense signal to assess for possible injury to the spinal cord. Diagnosis, however, is made clinically. There's a disproportionate impairment of the upper limb to lower limb, and there's also varying degrees of sensory deficits. Given that there's, of course, other musculoskeletal conditions that can be sort of mixed up with this, it's very important to consider this diagnosis sort of at the very end after a thorough workup. Something in play right now, this right here is this is a card that you get very used to during the spinal cord service. This assesses for sensory deficits, both pinprick and light touch, as well as motor function, both in the upper and lower extremities. And this is how we determine not only the level of neurological injury, but also what kind of spinal cord injury it is, either incomplete or complete. Right now, there's a discussion on determining if the difference of a score between the lower extremity motor to upper extremity of 10 could be considered a criterion. However, there's no clear consensus among the experts on that. So to be determined, but certainly something that may be in line. And I'll definitely refer to Dr. Abramoff towards the end of this presentation to see if that's something that he maybe uses in his practice to determine if someone has central cord syndrome. Again, management, if you are having active compression of the spinal cord that's resulting in neurological deficits progressing, as well as spinal instability, surgery is the first thing. A lot of these patients will have neuropathic pain. And remember the sensory cape-like deficits that we have. So anticonvulsant medications such as gabapentin and pregabalin are commonly used to treat this. Rehabilitation for this is very important, as it is for other spinal cord syndromes. The most important is to really preserve the range of motion. Splinting can be used, and we want to work on enhancing the mobility skills. Upper extremity deficits may attribute someone to think about more occupational therapy deficits, such as brushing, clothing. However, they're also important when it comes to ambulating for transfers and using a rolling walker for ambulation, and that can also impact their mobility down the road. So very important to address that for these patients, depending on the level of motor impairment they have. Prognosis really varies. For the most part, the order of the return to motor comes from lower extremities to bowel and bladder to upper extremities. If you have an absence of lower extremity neurological signs, as well as bladder dysfunction, that tends to be a positive prognostic factor. And also, like for some of these syndromes, being younger tends to allow patients to achieve independent ambulation more so than older patients. Finally, I want to go on to Brown-Séquard syndrome. This refers to the hemisection of the spinal cord, typically occurring in the cervical area. About 2 to 4% of all traumatic spinal cord injuries are actually attributable to this syndrome. Can occur from gunshot wounds, stabbings, from blunt trauma. Can also be non-traumatic as well, from a lateral disc herniation, as well as cyst radiation. There was also a case study of decompression sickness that I found online. Presentation is very important. It's actually a very commonly tested board question as well. At the level of the injury that takes place, you'll have a loss of all sensory modalities. However, below the lesion, and this is where we really want to start thinking about those different paths we talked about in the second slide, you'll have an ipsilateral loss of vibratory position sense from the dorsal columns, and then a contralateral loss of pain temperature due to spinal thalamic. So I really want to start make people think about where sort of these things cross over. Motor at the level of the lesion will be sort of flaccid. You'll have lower motor neuron size, may see fasciculations. However, below it, you'll have ipsilateral spastic paralysis. And depending on where the lesion takes place, remember that the spinal thalamic neuronal cell bodies terminate at the L2 area. You can have findings of Horner syndrome. So this is what would happen if we lose sympathetic nervous system. So you have mitosis, ptosis, ipsilateral, and also have loss of sweating. Remember, the dorsal column and the lateral corticospinal tract sort of decussate more so near the brain as opposed to the spinal thalamic tract that decussates at the level of the spinal cord. Right here, demonstrated by Dr. Walker, is one of the causes for spinal cord for the Brown-Séquard syndrome, although very, very rare. Hence, he had a case report on it, which occurred from manual manipulation. Other causes, as we mentioned, are traumatic and non-traumatic. You can have areas of preserved motor and sensory function as well, which can make the diagnosis of this really hard. And the purpose of this slide is to really talk about the fact that what we learned from the textbook may not always be represented in real life. Many times patients don't have all these pure findings that I just attributed to a slide ago. And depending on where this hemisection lesion is, other tracts may be involved as well, such as the posterior column. Here we have an MRI finding. As you can see, this hyperintense signal taking place of a hemisection, Brown-Séquard syndrome. Diagnosis is also, again, clinical. Definitely got a good history to figure out if there was any trauma to it. MRI is important to determine exact structures possible, delineate possible tracts that may be involved, and then X-ray for trauma to look for vertebral dislocation or fractures. Lab workups for any infectious etiology. Tuberculosis has been known to cause this syndrome as well, so certainly something to look into further. Management, like I mentioned, depends on the cause. For active decompression, important to do surgery to decompress, and then of course to rehab to work towards goals of functional ADLs. And then prognosis really depend on the cause of the injury. From patients from a post-traumatic standpoint do end up recovering their motor function. takes about a year or two for full motor recovery. However, a lot of it happens in the first couple of months, and then after that, it's sort of a gradual recovery down the road. It's very important to be, definitely encourage patients. Again, patients that are younger, have an incomplete injury, have prognostic factors for recovery. I kind of left this towards the end for all spinal cord syndromes. Very important to make sure we're preventing pressure ulcers. A lot of them will present variably with neurogenic bowel, especially with central cord syndrome. So definitely important to have a bowel program and have intermittent catheterizations for the neurogenic bladder, preventing DVT with PE, make sure anticoagulation prophylactically for 8 to 12 weeks, and then respiratory support, especially as the injuries on the cervical area may involve respiratory issues as well. And, all right, are there any questions that people have?
Tejas, I'm sorry I joined late. I was just with patients, so can I see the prior slides? Will they be available to us?
Yeah, sure. I can send it over to Dr. Abramoff with all the references as well, and he can maybe put it up on a SharePoint drive or whatnot.
Thank you.
And we'll also be sending out the recording of the lecture too.
Oh, great.
So if you want to watch the beginning.
Thank you.
Hey Tejas, it's David. Really good job. I thought it was a really thorough review. In fact, I was gonna let Clay know that you did such a good job. I feel like in the next SCI module, you should probably be giving this review for the rest of the residents. But I came in like a little bit late. I was just wondering for the anterior cord syndrome, did you mention sort of which specific like vessels can be sort of damaged to that syndrome?
Yeah, for the anterior cord, David.
Yeah.
I referenced the anterior spinal artery as the most commonly impacted. Occurs, I believe, from like cardiovascular surgery where the aorta is clamped. We actually had a patient, I believe, that developed like spinal cord infarction from like heart transplant surgery. That's sort of the artery I referenced to. I imagine there might be some other vasculature, maybe like a branch, but I did not get into that. No.
Yeah, the only thing I would add is that oftentimes on board or SAE, they'll also mention the artery of Adamkowitz. I think it starts confusing the cord around T9 and then below. So that's the only thing. That's the only other thing I would add.
Yeah, you're right. Exactly. Yeah. Artery takes over the closer part of the spinal cord.
Yeah, but overall, really good job.
Thanks, David.
Yeah.
Any other questions from the listeners? Tejas, really good job. Any thoughts or understanding of prognosis for these different syndromes?
Yeah, I believe the prognosis tends to be, it really depends on sort of age, sort of how the injury is sort of impacted, and depending on, where the other deficits are, it can sort of impact it, depend on that. There's also other areas to look at in terms of other risk factors that patients may have that may impact their prognosis. I believe that the central cord syndrome did have a favorable prognosis, more so for the younger patients. But I believe from my review, the prognosis tends to be overall, and again, this varies, tends to be the most favorable for patients with posterior cord syndrome. And in fact, when I was reviewing, there was discussion of not even including posterior cord syndrome as part of the incomplete spinal cord syndromes, given how rare it is, and the different levels of deficits that patients have, given that it can be unilateral as well. So.
Yeah. So actually, Brown-Séquard has the best prognosis of all spinal cord injury syndromes. Central cord syndrome, as you correctly pointed out, is really dependent on age. with young people having really good prognosis in terms of walking at least, and then older folks having pretty poor prognosis. I'd also, mention, you're right, the international standards for neurologic classification of spinal cord injury has removed over the last few years posterior cord syndrome from their list of incomplete spinal cord syndromes. So they have 5. They have anterior cord, central cord syndrome, Brown-Séquard syndrome, and then the ones that are kind of a little bit different, conus, medullaris, and cauda-equina syndrome, which are also considered part of kind of the spinal cord injury syndromes.
Oh, okay. Yeah, great. I didn't know that. So thank you.
Yeah. Any other questions? Yeah, I think this is a really great review, Tejas. I think it's really helpful to keep these things in mind, particularly the different elements of kind of evaluation and treatment when they occur, and where these deficits lie, because they, depending if it's a proprioceptive deficit or a weakness deficit, you really treat them differently. So thank you so much. We'll leave it there, and I'm sure we'll be back in another 2 months to do another spinal cord injury in service. So thank you, Tejas.
Perfect. Thank you guys so much for your time. Appreciate it.
Thank you.